Got everybody in now. So good morning. Welcome to our forum. We're hosted by Naples Concierge Health and then accompanied by Teresa Myers from the American Cancer Society. So just a couple things before we get started. Again, my name is Kelsey. So I'm going to be managing this Zoom conference. I am the member liaison over at Naples Concierge Health, so I might have met and spoken with a couple of you a few times. So just so you guys are aware, the session is being recorded, so that way we can post it on YouTube to be able to review later on. So if you prefer not to appear in the recording, you can just turn your camera off by clicking on the camera icon. Should be on like the lower left corner of your screen. And so then once we begin the presentation, I will pin our presenter, Dr. Marsh, to the main screen. So just make sure that you select the speaker view. It should be in the upper right-hand corner of your Zoom settings, just so that way you can always see his screen. Um, and then, as a courtesy to the other attendees, just please leave yourself muted throughout the presentation. If you guys have any questions, feel free to submit them in the little chat box in the lower right-hand portion of your screen, and then we will address those questions when the time allows towards the end of the presentation. And if for any chance you guys happen to get kicked out or lose connection, there should be a link in the email confirmation you guys received to be able to just click that and just rejoin the meeting. So as he introduced, Dr. Marsh is on the call as well, and then we'll begin by you guys just getting to hear a little bit from Teresa Myers from the American Cancer Society.
Okay, great. I didn't know if we were going to start the slides. Hi, all. I'm Teresa Myers. I'm with the American Cancer Society. Thank you to Kelsey and Dr. Marsh for inviting me to join. Today, I wanted to Dr. Marsh is going to be covering a lot about where we stand right now with cancer treatment. If we do have the slides, I'm not sure. I have a little bit of background about sort of the history of how we got here with cancer treatment. But what I really also wanted to do was introduce myself and let everyone know about the resources that we have through American Cancer Society very briefly. It's very easy to remember. It is cancer.org. And if you go to cancer.org, there are a ton of different points of information that you can access there, both about cancer treatments that are available, about help that is available, and about ways that you can help prevent your risk of getting cancer. And there's also an 800 number, which I'm just going to share with you all quickly, which is 800-227-2345. And so it's 800-227-2345. And 24 hours a day, 7 days a week. There are trained cancer experts who are available to help assist with any questions you may have. So, a little bit of background about me. I first came involved with American Cancer Society when my mom was diagnosed with cancer. And she's doing great now. She's fine, but it was a rough journey to get her to that place. And we use the resources through American Cancer Society as really a guide to help us. So I just welcome anybody to take advantage of that. And then I now work for American Cancer Society, and I'm happy to be an additional resource should anybody have any questions. So, yeah. Oh, so that's me and my
Yeah.
family. And so I just wanted to share a little bit of background with me. So, there, if you see in the picture from the wedding, both of my parents are cancer survivors, and I'm so proud to say that they're survivors. But my little one he's actually going to be 2 in just a month or so, and I'm so grateful that my parents are able to be these active grandparents in his life. And it's because of the research and the treatment advances that have happened. Um, where, if they had been diagnosed in the past, they wouldn't be here today. And so I think we should all feel really proud about how far we've come. But unfortunately, there's still a long way to go. And I know Dr. Marsh will be sharing some information about that as well. So this here shows also this one is just sort of like the history of how we got to where we are, but we don't need to focus on that too much. We can click ahead to the next one. This one right here, there is a QR code if you feel like scanning that, or the 800 number is there too. So please just keep that in mind if you or anyone you know needs any additional help too. And then on the next slide there, it has my contact information. So please feel free to reach out to me directly as well with any questions. I'm happy to assist.
That's great. Thank you, Teresa.
Right.
Today I wanted to talk to everybody about cancer prevention. So we're going to focus on not getting cancer in the first place, which is a topic I really enjoy. I really enjoyed writing this. We called it "The Fight Against Cancer Starts Now." So we want to start now, not when we have cancer. And that's what this is focused on. So a little bit about myself. I'm John Marsh. I'm with Naples Concierge Health here in downtown Naples, Florida. You can see here some things that our practice focuses on. We are very prevention focused. We deal a lot with patients who want to ensure that they don't get sick in the first place, which is a passion of mine. So that's why I put this talk together. We also did similar talks on Alzheimer's and heart disease and some other topics. So if you want to seek those out, they're available. So today we're going to talk about cancer. So first of all, we're going to talk about some statistics around cancer, why it's important to you, how many people get cancer. Then we're going to go through sort of what's the standard now, and that's the USPSTF recommendations. Then we'll talk about risk factors, how you can avoid getting cancer in your everyday life. And then we're going to talk about some cutting edge tests that are getting a lot of press and marketing these days, and a lot of people have questions about. So these are things we get asked about in our clinic, several times a week. So we're going to get the information out there and let you know what we know. And then we'll talk about, is there a screening protocol that uses these that makes sense? So let's talk about statistics. So cancer, 1 in 4 people will be diagnosed with some sort of cancer at some point during their life. So those are high odds. That's why this is important. The odds of dying of cancer, it depends on the numbers you look at, but about 1 in 10 men get it more commonly than women. And the most common cancers are prostate and biopsy. So this just impacts a lot of our lives. Another thing about cancer that we like to point out is that it's not necessarily a disease of old age. And I think for a lot of us, that's why we fear it so much. So it tends to strike people down in their prime, 50s, 60s. These are the most common years. It's not 80 and 90 like dementia, which has its own issues. But the way that it feels random and the way that it hits us when we still have a lot of life left in us, I think impacts a lot of people, and it, for that reason, is relatively, more important. So we're going to refer to this table a couple of different times. So we have on the left the most common cancers. This one is organized by most common, and then we're going to look at most deadly. So what I want you to take away from this is that there's not one of these cancers that is 50% of deaths or incidents. There's a lot of different cancers, and the biggest piece is 20%, and it gets smaller from there. So screening just for breast cancer is not a comprehensive strategy if you're trying to avoid cancer, and that's what this shows. Here's the same table, just organized by percent of cancer deaths. So you can see now we have lung cancer at the top instead of breast cancer. Prostate cancer has dropped way down, and we have colon cancer is number 2 at 12%, and pancreatic cancer number 3 is 12%. So the order of these changed completely by doing it by mortality instead of by incidence. Both are important. Getting cancer still causes morbidity, even if it doesn't kill you, but it's important to bear in mind the deadliest versus the most common. So a big piece of avoiding getting cancer in the first place is appropriate screening. So why is that? What's the rationale? If we catch a cancer earlier, it's more treatable. So a stage 1, stage 2 cancer is probably curable. A stage 4 cancer is probably not curable. So the earlier we catch it, the better off we're going to tend to do. Now, some things to consider are, what are the timeline of a cancer? For example, leukemias happen really fast. So if you're doing a screening test every other year, you're not going to catch leukemia because the acute leukemias develop over a course of weeks or months. If you do catch an early lesion and you remove it, are you actually preventing a cancer down the road? That's an important consideration. And then you're going to see, when we're looking at the actual information behind some of these screening tests, there's a little bit of softness in terms of, is this actually saving lives or not? And one of the big confounding issues whenever we're talking about this is lead time bias. So if you have a cancer for 10 years and you die of it in year 10, if we caught it on year 1, it makes it look like you lived 9 years. If we caught it on year 5, it makes it look like you lived 5 years. But did we really change the course of that disease by catching it earlier, or did we just catch it earlier? So that's just an issue that sort of pervades this space to be aware of. So let's talk about the USPSTF. So this is the United States Preventative Services Task Force. So these guys make the recommendations that most primary care doctors follow when we do screening for cancer. And they look at the evidence, they put out a report every couple of years, and this becomes sort of a guidebook for most providers. There are other people who put out guidelines. For example, the Gynecologic Society is going to put one out for cervical cancer, but in general, we're going to go over the USPSTF recommendations. So here are the current recommendations. This is, up to date, what they're recommending right now. So one is breast cancer screening, starting at 40. Another one is HPV and cervical screening. Another one is colorectal screening. We're going to talk about each of these in more depth here in a second. Another is low-dose lung CAT scan for lung cancer screening in high-risk populations. Prostate cancer screening, we'll talk about that. That's a controversial area. And then skin cancer screening. So these are the ones currently that have neutral or positive recommendations from the USP STF that they increase your life expectancy. So breast cancer. Breast cancer is probably the most studied cancer preventative modality. So the data on this is a little difficult to interpret because they've been improving the imaging over the years. So for example, right now, mammography, which has been around for maybe 5 years, is considered the care standard, whereas 10 years ago it wasn't, and some of the studies are that old. But in general, there's a trend that by adhering to a breast cancer screening protocol, you reduce the overall mortality of breast cancer by about 40%. Now, it is most effective between the ages of 50 and 69. So if you're 40 to 50, the information is a little weaker. And if you're over 70, it's a little bit weaker. The prime time to make sure you're doing it is from 50 to 69, but the recommendation is 40 and on. Any of these screening tests, they have risks, and we would be remiss not to address those. The biggest thing that happens with breast cancer is false positives and follow-up ultrasounds, follow-up biopsies. That's the risk of the false positive. But 20% mortality reduction by being adherent to the recommendations. The next one is cervical cancer. So there's 2 competing guidelines, and they both recommend some sort of combination of pap smears and HPV testing, both of which, they're not interchangeable, but they have different recommendations. Some combination of those should be happening from the ages of 21 to 65. The statistics on this are actually really good. So in an unscreened population, 5% of people get cervical cancer. In a screened population, 0.5%. So it's a less common cancer, but the screening is really effective. The risks are similar to breast cancer in that it's overdiagnosis, overtreatment. These appointments are not tremendously fun. And if you need a colposcopy or something periodically, then that's also not fun. But that having been said, this is pretty good mortality data if you undergo this. Colon cancer. So colon cancer, they recommend screening with colonoscopies or fecal occult blood tests periodically, starting at the age of 40 to 50. That's for an average risk person. So if you're higher risk for some reason, your uncle had cancer, colon cancer at 35, you have some sort of familial cancer syndrome, then you should consider screening earlier. But for the standard person, it's 45. The lifetime incidence of colon cancer is 4%. And there was a recent trial on this called the Nordic trial. For people who are adherent to getting their colonoscopies as they're supposed to, it reduces the risk of dying from colon cancer by 50%. If you are sort of adherent, then it's 30%. But again, that's a really good decrease in your incidence of cancer. And this is mortality data. So the ones that we've looked at are actually showing you that you live longer. Lung cancer. So lung cancer is selectively screened for high-risk people. They defined high risk as age 50 to 80 with a 20-pack year smoking history, and you smoked as recently as 15 years ago. Some notes about this. This is a low dose CAT scan, so it has much less radiation than a regular CAT scan. So that means that it's not going to, cause cancer while it's preventing cancer, because you're not getting as much radiation from this CAT scan as from a full diagnostic CAT scan. And this had a reduction in lung cancer mortality of about 20%. So that's pretty good. So far, these are the gold standards for results in studies to suggest that a screening test should be done. Note that these are all mortality outcomes. These tests have been proven to reduce your odds of dying of cancer, okay? Prostate cancer. So the USP STF recommends shared decision-making between the ages of 55 to 69. So what are the issues with prostate cancer screening? There's a lot of false positives. The number needed to treat is high, meaning that you have to do a lot of PSAs before you before you get that mortality benefit. And then the survival benefit when they check it is, 1%, 2%. It's not as high as the other tests. PSA has a high false positive rate because there's a lot of things that can make your PSA go up, like infections of the prostate. If you check someone's PSA through the course of their life, they will probably have a high number at some point. The other thing is that if the PSA is high, the next step is usually a biopsy. The test to treat prostate cancer is a prostatectomy, which is a pretty morbid treatment compared maybe to a lumpectomy in breast cancer, because it has an incidence of urinary incontinence and erectile dysfunction. So the risks are a little bit higher and the benefits are a little bit lower. So the official recommendation is just for shared decision making. Once you're informed, you decide if you want to undergo screening. Skin cancer is actually a neutral recommendation. So there is no evidence that seeing the dermatologist every year reduces your risk of skin cancer or increases your survivability. That having been said, the risk is lower. Somebody looks at your skin, that is not a unnecessary surgery. That is not a invasive thing to do. And then the other thing is, if they do, remove a mole or something that was not skin cancer, most of us are happy to have those removed. So a lot of people hew towards getting the skin cancer screening, and the reason is that the risk is lower, although the benefit is not super solid in terms of having been studied. So overall, if you're compliant with all of the USP SDF recommendations, what sort of benefit are you giving yourself? So they estimate that these recommendations have saved around 15 million life years since the introduction of recommendations, and they're spreading that across 417 million people. So if you do the math, that's increasing your lifespan by about 4 months. So not everybody's adherent is the issues. They estimate if people were perfectly adherent, then the number would be closer to 20 million, which would be increasing your life expectancy by about 6 months. So that's our talk on the USP STF recommendations and their mortality benefit. Let's talk about other ways to not get cancer. So first of all, we'll talk about lifestyle. So cancer feels like it strikes randomly. We all know someone who is healthy, took care of themselves, and they ended up getting cancer, and it feels like it's not their fault, and it's not fair, and that's tough. And that's one of the scary things about cancer. There is certainly truth to that. I think that everyone needs to know, though, that lifestyle does affect your cancer risk. So first of all, smoking. Of course, that's not a surprise, but smoking is associated with 19% of lung cancer cases. I'm sorry, 19% of cancer cases and 28% of deaths. They estimate that overall 40% of cancers and 44% of deaths are associated with some sort of lifestyle factor. Another one is excess body weight. Fat in general, and especially abdominal obesity, is pro-inflammatory, which creates a milieu where cancers can, they have a better chance of taking hold and spreading. So that's associated with 7.6% of cases And then alcohol consumption, of course, especially heavy alcohol consumption. About 5% of cases are associated with alcohol consumption. So while there is certainly a random nature to cancer, it doesn't mean that there's nothing that we can do in terms of lifestyle and exercise to prevent it. So here's an example. If you increase your weight by 5 units above what's considered a healthy BMI, which is 25 kilograms per meter, then your risk increases by 20%. So that's maybe 15 pounds for most people of an average height. So for every 15 pounds you're overweight, you're increasing your odds of cancer by about 20%. So it tends to affect GI cancers, pancreatic, esophageal, gallbladder. And then the other thing to note is that even if you don't change your weight, exercise reduces your risk of cancer as well. So even if you're not exercising to lose weight, exercise reduces your risk of cancer. And they've studied this specifically in bowel and breast cancer. So this table are the cancers without a USP STF screening. So we went over the USP STF and we covered breast, pancreatic, colon. So what's left after we've screened for those? What are the cancers that are not covered by the standard screening? One that was a pretty heavy hitter is pancreatic cancer, 12% of cancer deaths. Prostate cancer, we talked about how the current blood test screening is not super efficacious, so I left that on here. Liver and bile duct, 7%. Leukemia is 5%. And down bladder, kidney, endometrial, thyroid, we're getting down to the smaller percentages, but all of these add up to quite a bit. So 51% of cancers by incidence and 48% by mortality do not currently have a standard screening protocol. If we had a standard screening protocol, hopefully we could get earlier diagnosis. Hopefully we could prevent cancer deaths down the road. That would be the goal. That would be the gold standard. Anytime we're screening for more cancer, we're going to run a risk that we're going to find things that are not cancer and undergo tests that are not extending our life. And then we also run the risk, just the psychological stress. If you have a test and it says you might have cancer, how are you going to deal with that while we're waiting for testing? And how are we going to deal with the stress of maybe an indeterminate finding? So these are the risks to considering further testing. That having been said, there are 2 tests that are really popular right now we're going to talk about. Before we do that, let's get an overview, the idea of screening tests and some of the numbers we're going to look at. So one thing is sensitivity. So sensitivity is a test's ability to detect all of the cancers that you're looking for. So something with a high sensitivity is going to detect every single one of the cancers, but it might have more false positives. Specificity is a test's ability to, if it's positive, you actually have cancer. And these end up having a big effect depending on how common a cancer is. So I'll do one quick example and then I'll get off the math, I promise, but it is important. If a cancer is present in 10% of people, so 100,000 people out of a million have the cancer, and your test has a 99% sensitivity. That means if you test a million people, you're going to catch all of those cancers, plus you're going to catch an extra 10,000 because you have that 1% sensitivity issue. But if the cancer is only 1 in a million, then you're going to catch that 1 in a million, hopefully, but you're going to have a false positive rate that's going to way outweigh that one person that you caught. So depending on how common a cancer is, the importance of sensitivity and specificity are different. So that's what makes screening tests really hard. If you're going to test every single person in the country, you need a really high specificity and you need a decently high sensitivity. So that test is meaningful for you if you're the person who it comes back as positive for. So moving on from that, we're going to talk about the Gallery Grail liquid biopsy and the whole body MRI, which are 2 tests that are being heavily marketed right now and a lot of patients are getting. And I think most people want to be informed about these. So what is the Gallery Grail test? So the Gallery Grail test is what's called a liquid biopsy. There's more than one brand out now, but Gallery Grail was the first and sort of gold standard. So what this test is, they draw a sample of blood. It's a pretty big sample of blood, and they test it and look for what's called cell-free DNA. So this is not your DNA. This is just DNA floating around in your bloodstream. This is the same sort of DNA they use now to tell you a baby's sex from a blood test if you or one of your loved ones has had that. So they're able to take cell-free DNA, they amplify it and they analyze it, and they look at does this DNA have mutations that are associated with cancers, and does it have what's called a methylation pattern that are associated with cancers? And based on that DNA that's floating around in your blood, that is not your DNA, it's DNA from something else in your body, they're able to tell if there is a tumor somewhere in your body. So the benefit here is that you can detect a cancer before it's visible. So this is being studied as a population-based screening test in the United Kingdom. So the first study that came out about this was called Pathfinder 1, and they're now on the Pathfinder 2, and the initial results were pretty encouraging. So the specificity of the test was over 99%, which that sounds great. But remember, the issue is how common are these cancers? So the positive predictive value was 43%, meaning that if you tested positive for cancer using this test, it was still only a 43% chance that you actually had cancer. So because you're testing for something rare across a lot of people, it creates issues in the test. And if you're going to consider a test like this, you have to ask yourself, okay, if this comes back as positive, am I able to psychologically deal with the fact that it's really a 50-50 shot? And now we're going to do more testing to go look for that cancer. If it says you have pancreatic cancer, 50-50 shot. Now, before you had the test, it was a, 1 in 100 shot. Now you're that much more likely, but now we do the follow-up MRI, endoscopic ultrasound, whatever it is, to try and define if you actually have that cancer and if there's something there that needs to be removed. Pathfinder 2, they just did a press release for this on June 18th. The full study is not out yet, but reportedly the results of that were even more encouraging than Pathfinder 1, and that it had a really good specificity, the sensitivity improved, but we're waiting on that final data. The other thing we talk about is the CSO accuracy, the cancer signal origin accuracy. So that is the ability to be able to tell with that DNA exactly where the cancer came from. Sometimes you might say, okay, there is a cancer, but we don't know where it is. And that again puts us into a position of, okay, well, how do we follow this up? What do we look for? And these things are all being developed because these are cutting edge tests. So if you're considering one of these tests, these are questions you need to think about. Do I want to do a cutting edge test that might lead to some clinical scenarios that aren't super well defined? Some people are very comfortable with that. Some people are not. Drawbacks. One is we're talking about detecting cancers. We're talking about are they present or not. We're not talking about mortality benefits. When we were looking at the USP STF, we were talking about proven mortality benefits. None of these have been proven to improve your mortality. If you get a Galleri Grail test and it comes back as cancer and we treat that cancer, it makes sense. You would think that would improve your mortality, but it's not been studied to that degree yet. Cost, these are not covered by insurance yet. The Galleri Grail test cost about $3,000. Is that a cost you're comfortable bearing or not? That's up to you. That's a personal decision. And then we talked about it sometimes leads to situations where these tests are not as common, it's not as routine how to deal with some of these tricky issues, and that's going to be a risk of doing anything cutting edge. Let's talk next about whole body MRI. So, oh, by the way, if you have any questions, put them in the chat. We'll go over them at the end. Kelsey will read them out to us. Whole body MRI. So whole body MRI is just that. They put you in a tube and they put you through the MRI. Now, what you may not realize is that this creates limitations on the type of MRI you're getting. So if you get an MRI of the brain, that MRI is specifically tuned to look at your brain. And if you get an MRI of your liver, that MRI is specifically done on a protocol to look at your liver. But because we're trying to do your whole body in a reasonable amount of time, this has compromises in terms of the protocol that you're using for the MRI. So that leads to some things that might seem counterintuitive. You would think you look inside me, you see the cancer, easy peasy, and I'm done. Unfortunately, because of the way these have to be done, this is just not that far along yet. So you need to be mindful of the limitations. One is you would think that this would be a good screening test for breast cancer because if you have a indeterminate mammogram, they do an MRI to follow it up. Well, this isn't the breast protocol MRI, so it actually is not great for detecting small, early breast cancers. You couldn't use this to replace a mammogram, for example. Colon cancer, Colon cancers tend to start as adenomas, and they're flat and they're small in the colon. MRI doesn't have the resolution to detect that. Thyroid cancer, again, the protocol is not specific to thyroid cancer. So while it makes sense, let's look and see if there's a cancer. Because of the protocol that's being used, it doesn't detect every single cancer that you might think. One thing to point out about MRI, I see a lot of confusion about. MRI is actually low radiation, so that's one of the benefits. Unlike a CAT scan, which uses a lot of radiation, an MRI is actually a magnet. It's not radiation. So you could do a ton of MRIs and it's not going to cause cancer. So that is one of the reasons that people are excited about this as a modality. Can we improve the protocols and get higher sensitivity and specificity numbers with the MRI? If so, we can do it on everybody. It's just a cost issue, and how do you lower the costs? So that's one of the reasons that people are so excited about this as a modality. So benefits. So let's talk about the study. So when they did general screening of populations with MRI, which most of these studies are pretty small, 2,000, 5,000 people, they found cancer in 4% of those people. Of those 4%, that was real cancers that were found. Again, no mortality benefit data. We don't know if that actually saved those lives, if those cancers were going to disappear, or if they were going to kill that person. We have no way of knowing at this time. The risk is false positives. You get a whole body MRI. These always come back with 20 findings. You have arthritis of the spine. You have a bad shoulder. You have, all sorts of things. And if it's not bothering you, then it's probably not a meaningful clinical diagnosis. Some people like to look at that and they say, I knew it. I knew I had arthritis in the spine. Some people, that's a source of stress for them. They don't want to know that information, or knowing it changes what they're doing. So those are some things you need to ask yourself. That's why these tests at this point are a personal decision. Cost, again, whole body MRIs are expensive. They're between $3,000 and $4,000, and they're not covered by insurance. One point about whole body MRI, all the tests I talked about were in a general screening population. Whole body MRI does have strong data in some people who are high cancer risk. There's a syndrome called Lee-Fraumeni syndrome, where you're prone to cancer. And in that syndrome, it is proven to help catch cancers early and improve outcomes. If you are someone who has a personal family history of cancer and a ton of different family members, then you may say, look, they haven't genetically defined what my issue is, but everybody gets cancer. We're obviously prone to it. So I don't think I'm a general person out there in the population. I think I'm a high risk person, and that can be a reason to do a whole body MRI. And then that means it is going to be more effective. So we talked about no mortality data, expensive and benign findings. Pros, you're not getting radiation exposure, so you don't have to worry that you're going to give yourself cancer, and it's non-invasive. The test takes about an hour and a half. It's loud, it's cramped, but otherwise, there aren't a lot of negatives to it besides those we mentioned here. So MRI, as I mentioned, they can change the protocols, they can adapt them, they can use AI to screen the tests, and all of those things are under study. And that's why this one is a bit of a moving target. So every time there's a study, then there's the counter argument, oh, well, we've improved the test since the last study, because you're not developing new chemical methods. You're going in and changing how the computer runs and looks at things. So the efficacy of this is constantly moving forward. The studies may not be indicative of the cutting edge, and that makes it a little hard to interpret how this is for people. There are efforts for increasing the access to whole body MRI, and the idea is that this is you start with the people who can afford it, but you can drive down the cost of the MRI, and eventually it could become a candidate for a population level screening tool. So those are the modalities we were going to cover. We talked about preventing cancer. We talked about the sort of gold standard USPSTF. We talked about some popular tests that are coming out and the evidence behind them and why you may or may not consider them. In conclusion, USPSTF, there's nothing that replaces it. Getting a GRAIL test or a whole body MRI does not replace the USPSTF. You need to undergo those, and I think that evidence is really strong. To me, the GRAIL is the next best studied test. It is being studied in a population basis in another country. The data looks really good. To me, the whole body MRI is something you can consider. It's not dangerous. It's not going to give you cancer. You need to think about if you have a false positive result, if that's going to be something that is going to create you a lot of psychological issues or not. One point is that the Grail is not really very sensitive or specific. We know it's got an issue with kidney and prostate cancer, and the MRI is good for kidney and prostate cancer. So if you have that as a particular concern for some reason, family history, for example, then whole body MRI is sort of going to fill that gap potentially. So what might be a clinical protocol that you would apply this to? So one is I'm a big advocate for you keep up with the USP STF. You don't trash that. That's throwing the baby away with the bathwater to me. So we're going to stay on top of that. Two is considering a Grail test if you have a family history or a particular concern of cancer. And I'm pretty comfortable using that as a screening test as long as patients understand the risks and benefits and why they're doing it and if they can afford it. MRI, if you have a particular concern for GU cancers, or if you're just the sort of person who's really comfortable with experimental things, there's no reason except for cost that you would have to avoid it. There's no evidence that it worsens your outcomes. So what you would want to do is do the USP STFs, do one of these other screening tests every 1 to 2 years to make sure that you're getting maximum benefit from those. So if you're interested in discussing these further, if you want to work with physicians who deal with these decisions, routinely like we do, or if you just need help, feel free to reach out to us. There's a QR code you can look at. Here's our email and our website. We are in downtown Naples if you need help or have any questions or anything. I'll kick it back to Kelsey now, see if we had any questions in the chat. And if anybody wants to drop those now, then we'll do our best to address them. Thank you.
Thank you, Dr. Marsh. I don't see any questions in the chat, but is there any that anybody had that just didn't get the chance to put in there? No? Okay.
Okay. All right. Well, I appreciate everybody's time. Thank you for joining us. If you need anything, don't hesitate to reach out and give us your feedback too on the talk and let us know what was helpful and what wasn't. We do a series of talks in person. We're going to do more webinars if you're interested in hearing more on other prevention health related topics. Thanks.
Absolutely. Thank you, Teresa, for joining us. Appreciate it. Thank you, everyone. Bye.